We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 132 and Glaucoma Session 36. And today we have with us Professor Surinder S. Pandav, and he'll be talking on surgical approaches for coexisting glaucoma and cataract. I request Dr. Vanitha ma'am to please introduce her.
Thank you very much, Rolika. It is indeed my great pleasure to welcome Professor Surinder Singh Pandav. He is the head of ophthalmology at the Advanced Eye Center, PGI Chandigarh, and has only recently taken up that position, I think in February this year. He is also currently president of the Glaucoma Society of India. He has extensive experience in ophthalmology, over 30 years and about 20 years in glaucoma, and has been instrumental in establishing the glaucoma services at Advanced Eye Center at Chandigarh. He did his research fellowship in 2005 and a glaucoma clinical fellowship in 2006 at Perth in Australia at the Lions Eye Institute and Royal Perth Hospital, and was also a visiting professor at the Centre for Eye Research Australia, Melbourne, from 2014 to 2016, where he was involved in basic research and understanding of functioning of glaucoma drainage devices. He's also been instrumental in coordinating the Glaucomatous Optic Neuropathy Evaluation Project, the GON project, which is an internet-based system for evaluation of optic disc assessment skills amongst ophthalmologies and trainings. And actually, in fact, it is an excellent resource for trainees. I would recommend that very highly. He's been actively involved in research and has published close to 150 papers, 15 book chapters, written books as well, and delivered hundreds of talks in various conferences and seminars. His main sphere of work is patient care, medical education and research. And in addition, he's also very passionate about teaching ophthalmology to support systems in the general public. He's also conducted several educational workshops and wet labs for ophthalmologists in the northern region. Other leadership positions that he has held includes president of the Chandigarh Ophthalmology Society. He's been general secretary, North Zone Ophthalmological Society, and has previously also held the position of general secretary, Glaucoma Society of India. So with these words, I would extend a very warm welcome on behalf of Team CFS for him to deliver his talk today on strategies for coexisting cataract and glaucoma surgery. Dr. Pandav.
Thank you, Dr. Vanitha, for the kind words. And also thank you to the CFS for this invitation to speak on this platform. Can I share my slides now? And I have two very good friends of mine in the panel, so it's an additional pleasure for me to be on this platform, and I look forward to talking to them as well during the course of this lecture. Harsh and Pradeep. Okay, so can you see my slide?
Yes, sir. Yes, sir.
So I will be talking about approaches for coexisting glaucoma and cataract. Okay, so I have no financial interest in any of the procedure or the products if I happen to mention in my talk. Glaucoma and cataract, they often coexist because they are, both of them happen, in the later half of the, kind of years beyond 40 plus. So both our diseases are common at that time, and so the overlap is natural. And is kind of believed that if you look at the elderly population with cataract, about 10% at least would have glaucoma or ocular hypertension. And we know both are age-related problems, so that much overlap is kind of expected. We also know that IOP lowering is the mainstay of therapy, and surgery is often needed to control intraocular pressure when medicines fail. The question is, what is the best way to treat if the medicines have failed? That means, what is the best way to do surgery, or what surgery is the best? Now, that point is very debatable and has been debated and considered many times, and you'll find plenty of literature on this. So my effort would be to, revisit the literature today and see what is the current state of affairs and, what are the concepts behind. When you are deciding to do surgery in these patients, when you have cataract and glaucoma together, some of the considerations are the glaucoma phenotype and what kind of glaucoma is there, because that could alter your surgical approach to this patient. Also, you have to look at the amount of damage, whether it's early disease or is advanced glaucoma. Also, the amount of cataract, whether it's insignificant cataract or is leading to a visual handicap, visual disability. Also, you have to look at other extraneous factors like access to healthcare, whether the patient can come to you or cannot, availability of the follow-up, and also economic and other social parameters. They also come together for the final, decision to what kind of surgery you want to do for these patients. So it's very important, basically, to know the main aim for doing surgery is basically to preserve vision and improve vision if possible, and also with that some improvement or at least maintenance of quality of life, because we know both glaucoma and cataract degrade quality of life, whereas cataract-related decrease in quality of life is reversible, but glaucoma is irreversible. So it's very important to keep that in mind. And our approach will also be determined by the magnitude or the high intraocular pressure or the target IOP requirement, that how much we want to reduce. Amount of glaucoma damage I already mentioned, and the cataract, as I already mentioned. And among phenotypes, at least 3 phenotypes must be identified from this lecture point of view: the POAG, open angle glaucoma or angle closure glaucoma, and pseudo-exfoliation glaucoma. And since we are doing surgery and they will need glaucoma surgery or cataract surgery or both, we have to be aware, we have to be mindful of the anesthesia that we use, as well as the IOL, the implant in these eyes, because all these things can affect the ultimate outcome in these patients. So we have basically 3 things here. We have glaucoma surgery, we have cataract surgery, that's phaco-emulsification. In glaucoma surgery, mostly we'll be talking about trabeculectomy, though we could put tubes as well and combine with cataract surgery if required in certain cases, but by and large, we'll be sticking to trabeculectomy. In cataract, we will stick to phaco-emulsification particularly. And in combined, again, we have phaco plus trabeculectomy. And I'll also touch upon a little bit on the phaco plus MIGS, that's minimally invasive glaucoma surgery, because this is, again, very frequently discussed in literature, and you'll find a lot of literature where cataract surgery is often combined with one of these procedures to control glaucoma or ocular hypertension. So a little bit of that will also be there. So this is basically a summary of the overall view of these 3 procedures or 3 approaches. If we do trabeculectomy, now if you have glaucoma and you have cataract, trabeculectomy still remains a valid choice because this will lower intraocular pressure and hopefully will preserve visual function. However, the downside of trabeculectomy is that it's a bit challenging, especially if that you have cataract or you have some other pathology associated with it, or the AC is shallow. And even if there's no cataract or some cataract is there, invariably after trabeculectomy, the cataract will progress or it will form. And it's mentioned in literature that the rate of cataract formation could, is quite variable, 6 to 58% within 1 year. So what that means is that the significant number of these patients would actually need cataract surgery within a year's time. And when you do cataract surgery, there's again becomes an additional risk for blast failure. So you have to basically keep that in mind as well. We could do just phaco-emulsification because they have cataract. You control IOP, or and do phaco-emulsification only for these patients. Now, the advantage of this approach is that the AC becomes deeper, then the subsequent maneuvers, they become easy in the anterior chamber. Cataract surgery also leads to some reduction in intraocular pressure. And of course, there's a visual gain, which is very gratifying to the patient and also builds the confidence of the patient in your practice. The downside is that there might be an increase in IOP, and especially within 12 to 24 hours, there's usually a spike after phaco-emulsification. And if that's not controlled, it could lead to some decrease in visual acuity because these eyes are vulnerable to damage. So a eye spike could damage the optic nerve a bit further, and that would be not good situation. And we can also combine the two procedures. We can do in the same sitting, we do trabeculectomy and as well as phaco-emulsification, what we call a phaco-trab or combined surgery for glaucoma. And here we have advantages, or the potential advantages are there many. It will lower intraocular pressure, preserve visual field, AC will become deep, IOP will come down, there would be visual gain, hopefully. And now also there's a single surgery, you don't have to come, twice. Some financial gain as well as hospital visits could be reduced. But somehow combined surgery still has many uncertainties, and most of the surgeons, they won't do a combined surgery unless they have other two options are not there. No, so that basically means even if there are advantages, so because the predictability of this, the combined surgery is much less than phaco and also less than trabeculectomy. Now, phaco outcome is very predictable. You can almost 99.5% guarantee, what is going to happen. Trabeculectomy is not that predictable, but still fairly predictable, I would say. But combined surgery tends to be a little less predictable, both of these. So probably that's the reason that because there are more uncertainties there. So there's a less confidence in this procedure, by most of the glaucoma surgeons. So let's talk about the trabeculectomy first. So trabeculectomy still remains the gold standard for reducing intraocular pressure. This would be the procedure of choice when visual rehabilitation is not an immediate concern. That means the patient may have cataract, but it's not that much, and he has a reasonably good vision to go around and do his, day-to-day activities, and there's no functional disability. The trabeculectomy would be a procedure of choice there. But as we are saying that there's a coexisting cataract also, that means the vision would be down in these patients, and that's the situation where we have to look beyond just trabeculectomy. The advantage is that there's a high success rate, 80 to 90% is quite common. Of course, it declines with the passage of time, and if you go 3 to 5 years down the line, the success rate might come down to say about 50% or 60% in that range. But still is a good success rate. And if the trabeculectomy start failing, you still have option of using medicines and other measures. But it has its own complication, and that's why we look for other procedures. There's no improvement in the vision because of the trabeculectomy. Actually doesn't cause any improvement of the vision directly. It helps in preserving the vision, but it won't be improving the visual acuity. Some decrease in vision may happen actually in early follow-up period. So it's kind of the other way around. So the patients have to be counseled for that, and they have to know that they may expect a decrease in vision after trabeculectomy, which invariably recovers to at least to the preoperative stage. The AC may become shallow. There might be an aqueous misdirection, and some snuff out phenomena, which is rare, but sometimes it does happen, and one has to be aware of. So the surgeons are basically a little worried about these last two phenomena. And also development and progression of the cataract happens, as I mentioned earlier. So a significant number of these patients, they would need cataract surgery in the post trap period within a year or two. And we know that if we do cataract surgery, the BLEV tends to fail. So again, there's a bit of counterproductivity there. Now, cataract surgery alone can also lower IOP. So let's consider what if we just do cataract surgery, and where cataract surgery can be a better choice. There are a number of studies available in glaucoma patients and as well as in ocular hypertension patients, where doing cataract surgery reduces intraocular pressure. And this is one of the recent studies published in 2020. This is from Australia. The eyes with preoperative IOP of more than 24 millimeters of mercury had a mean IOP reduction of about 4 millimeters of mercury after phaco-emulsification alone. And 80%, the majority of these eyes experienced at least 3 millimeters IOP reduction. So that means if you do phaco-emulsification only in patients with glaucoma or ocular hypertension, this is in relation to POH, open angle glaucoma. So at least 3 millimeters of mercury IOP reduction can be expected. So that means if the preoperative IOP is 24 millimeters of mercury, just by doing cataract surgery, you can reduce it to somewhere around 20 millimeters of mercury, and then you can use a few drugs to bring it under, within a reasonable range. So that is possible. Also, the cataract surgery, even in normal persons, it lowers IOP, but that's much lower, about 1.53. And this reduction in IOP is actually sustained. It's not a temporary phenomenon. And in this study, they seen that in open angle glaucoma, about 1.8 to 2 millimeters of mercury IOP reduction could be there till about 4 to 5 years. But overall, phaco and even extra capsule cataract excision would reduce IOP in open angle glaucoma 2 to 4 millimeters of mercury. So again, basically telling the same thing. Important to remember here is that the IOP reduction because of cataract, after cataract surgery, is actually related to the preoperative IOP or baseline IOP. And this is very important. This is an important slide. So I would like you to remember this. So if the preoperative IOP is somewhere in a mid-teens, then you can see there's about 1.5 millimeters of mercury, 1.6 millimeters of mercury IOP reduction. And as the IOP increases, the reduction in also goes up. So in 25, somewhere around 25 millimeters of mercury, you can expect our 6.5 millimeters of mercury IOP reduction just by doing cataract. Now, this is important because subsequently we'll talk about the MIGS. And when you read MIGS, they all procedures actually claim a good IOP reduction. And all these MIGS procedures are done along with cataract surgery. So sometimes it may be, so you have to keep in mind that IOP reduction is after cataract surgery happens, and that is a function of baseline IOP. Now, what about the angle closure glaucoma? And again, the IOP reduction in angle closure glaucoma is actually more than what we see in an open angle glaucoma. And this is a little older data, 2001, but a good data. You can see here we had 74 angle closure eyes and 68 open angle eyes. And after phaco-emulsification, you can see there's a significant reduction in both the situation. However, the angle closure glaucoma had higher, almost 7 millimeters of mercury IOP reduction following phaco-emulsification, and open angle glaucoma a little lower, but again, significant IOP reduction. The important thing was that in angle closure glaucoma group also needed less anti-glaucoma medicines in the post-operative period. So that means there's an additional benefit if we are doing phaco-emulsification alone in angle closure glaucoma. This is one of my patients, who is one-eyed patient, and he had a decreased vision for a couple of years, 4 or 5 years. And when we saw her, the pressure was 34 millimeters of mercury, and there's an advanced disc damage, 0.9 CD ratio. AC was shallow. So she was diagnosed as having left eye angle closure glaucoma. We did laser iodotomy, and put her on anti-glaucoma medicines, which brought her down pressure a little bit, but it was still high. And subsequently, we did just phaco-emulsification. And you can see after phaco-emulsification on day 1 post-operative period, the eye looks very good. The cornea is clear, AC is formed, well formed. And this is it's like any other cataract surgery, basically. And I have a follow-up of IOP for follow-up for 2 years for these patients. And you can see in the beginning, pre-operative at percentage for 24 millimeters of mercury. We did laser iodotomy, came down to 22 millimeters of mercury, but with multiple drugs. And then we did cataract surgery, and the IOP went down further. And at 1 month, it was 10 millimeters of mercury. which subsequently rose a little bit to 14 milliohms of mercury, where it was maintained for the next 2 years. And that was without any anti-glaucoma medicines. And the line below shows you the anti-glaucoma medicines. You can see that in the beginning, there were 5 anti-glaucoma medicines. That means she was on oral acetazolamide as well. And subsequently, we could withdraw within all the medicines within 3 months follow-up. And after that, she was drug-free. So I think this is a very good outcome for these patients. And many of our patients actually follow a very similar trajectory. This is another patient of angle closure glaucoma where I did phaco with goniosynuclein. So I usually don't do goniosynuclein, but I think literature talks about it, so sometime I do it. And after phaco-emulsification, this is day 1. Again, idea is basically the IOP was controlled on day 1. And you can see the eye looks very quiet. The cornea is good. There's an air bubble I left because I wanted to keep the AC deep after goniosynuclein. But this is a very gratifying result because you can see the eye is quiet and cornea is good and visual acuity is improved, IOP is controlled. So that's what we want. This is our own data from 100 eyes of 79 patients, which is published in IGO as well. So here what we did was that we did cataract surgery for all angle closure glaucoma patients, irrespective of the stage, like whether they were advanced, mild, moderate, or severe. And so even when the IOP was uncontrolled with maximum medical therapy, instead of doing trabeculectomy in these patients, we just removed the cataract and followed up these patients. And the results, as you can see, in the beginning, the baseline IOP was high in all these patients, but at the final follow-up, say more than 1 year up to 2 years, basically, you can see after 1 to 2 years time, all these are maintaining a good IOP control. Now, important thing in this study was that 20%, 20 eyes in these patients actually have uncontrolled glaucoma, even with oral acetazolamide. And we did them, we did phaco-emulsification in those patients as well as under mannitol. And in the post-operative period, 80% of these people also had controlled intraocular pressure with some anti-glaucoma medicines. Only 20% of these, 18% actually, of these patients needed filtering surgery. So among all of the uncontrolled glaucoma patients, angle closure disease, only 20% actually ended up with surgery. And if you take the entire group, the ratio, the percentage of people who needed trabeculectomy or filtering surgery was actually much less. So that actually suggests that removing cataract only in angle closure disease is a good option. What about phaco versus MMC trap in angle closure disease? So this is another study that was published in 2013, so it's not very old. 50 eyes IOP reduction at 2 years follow-up was seen, and one group had phaco-emulsification only, and in the other group you had trabeculectomy with mitomycin C. And you can see the IOP reduction in both the groups is more or less similar, a little better in trab, but not substantially different. And the advantage was that the anti-glaucoma medicines required in trabeculectomy group, they were also on the lower side. So there was some benefit in doing trabeculectomy, but there was not a substantial benefit. On the other side, if you look at the complications rate was 10 times higher in trabeculectomy group as compared to phaco-emulsification group. So that actually, again, speaks in favor of doing a cataract surgery in angle closure glaucoma before you consider filtering surgery for these. So cataract surgery appears to have many benefits in angle closure glaucoma at least, and it reduces intraocular pressure. It also preserves vision, and it also maintains quality of life. But in addition to that, there are other benefits as well. What you can say the associated basically benefits. Those are like disc evaluation becomes better because the visibility becomes better. You can see the disc much better. So the follow-up of these patients from glaucoma point of view becomes more reliable. The visual fields can be done more reliably, and you can do good fundus pictures, and OCT and other imaging for glaucoma patient becomes better. So those are the additional advantages in these patients. Another issue that should be considered, and I mentioned earlier, is also the choice of IOL. So if you're doing an IOL surgery in these patients, I think the IOL, you have to be careful what kind of IOL you want to put, because in glaucoma patients, when they have a visual field defect, there's also a overall reduction in the contrast sensitivity. So if you have an IOL which reduces contrast sensitivity, that will actually make the patient worse. So in that regard, multifocal IOLs, which are known to reduce contrast sensitivity, should not be put. They should be avoided in glaucoma patients. And multifocal IOLs have other disadvantages as well, like they not only reduce contrast sensitivity, but they also produce artifacts when you're doing visual fields, and also artifacts in the OCT. So subsequent glaucoma, the follow-up with visual fields and OCT also becomes a bit unreliable, and you have to establish again new baseline perhaps for these patients. And if you're doing a combined surgery, then you might be putting toric IOLs if there's an astigmatism. Now, again, you have to be careful, because after filtering surgery, the axis might change. So the axis that you calculated preoperatively may change in the postoperative period, and you might be disappointed. So again, that has to be kept in mind. And also there might be some refractive surprises, because getting the right IOL power will also be difficult, especially you're doing a combined surgery, that's phaco and trabecular. So these are again disadvantages when we talk about filtering or combined surgery. So that also you remember. So refractive surprises, because sometimes the lens iris diaphragm doesn't settle where you want it to settle. It may be a little anterior if there's a shallow in the AC. So that means the effective position of the lens will not be the same as anticipated during calculation of the IOL formula. So that also should be kept in mind and communicated to the patient. Best choice for these would be an aspherical monofocal IOL. That gives you the best the vision for these IOLs, for these patients. Now we come to the third option, that's the trabeculectomy and combined procedure. So you are doing now trabeculectomy as well as a phacoemulsification. Now, this is an area which is a little very much debated, as I said earlier, because there's lack of consensus here. The surgery is complex. The healing process, takes a bit longer. There's more inflammation in these eyes because you are doing a double surgery. And also that makes these eyes prone to the cystoid macular edema and related complication, and also a little more chances of graft failure, among other complications of the cataract or filtering surgery that can also happen. But these are some of the concerns that we all have. Now, this was angle closure glaucoma, and I did phaco-trabeculectomy for this patient. Now, you can see I usually remove the lens first and do trab later in angle closure glaucoma. But sometimes you have to do, phaco-trab, because like in this patient, you can see the laser iridotomy has been done twice. The AC is actually very shallow, and there's a synechia there. Sure, you can appreciate the peripheral iris is almost sticking. So I thought even if I do phacoemulsification and deepen this anterior chamber, the synechia will still be there, and I didn't expect the IOP to get controlled. So this will be one of the indications for me where I could do a combined surgery in angle closure disease. So I did combined surgery for this patient, and because the conjunctiva economic spiral is pretty good and is quite high otherwise. And this is on 7th day postoperatively, and you can see the trabeculectomy site looks pretty good. There's a shallow bleb, but I have those, releasable sutures. The IOP is reasonable at this point of time, but I have IOP to releasable sutures, and I can pull out anytime. It's only 7 days. So if you want to increase the filtration. So from glaucoma point of view, I'm quite happy. However, on the cataract point of view, you can see that there's still a bit of a corneal edema there, and you can see Desmond's fold, and some fibrinous kind of a reaction in the anterior chamber. So these eyes, they do have, I think this also disappeared with continued therapy, but what I'm saying is that the healing time, the recovery time is a bit longer if you're doing a filtering surgery, and that could be a little bit of concern, and that can also compromise your trabeculectomy result later on. This was another patient who came with high pressure, 38 millimeters of mercury on 4 or 5 drugs. The pupil was a little irregular, so we did ask about trauma and other things, and probably some suggestion that he had some childhood trauma. But IOP was a high, yeah, the AC was good depth, but and you can see there's a nucleus close, so there's a cataract, and the vision was poor. Gonioscopy, open angles, more or less, you know, and the inferior angle did suggest some increased pigmentation, and we were kind of considering possibility of angle recession here, but it was not kind of a definite. So I did combined surgery again in this patient, and you can see there's a bit of a hyphema in the next day, post-operative day 1, and some, again, blood plus some fibrin in the pupillary area. And this eye is, the below area is congested. It's very early, so congestion would be expected, but I would be concerned in this eye again. I have to make more effort to make this bleb survive, and hyphema and other things would probably disappear with time. So what does the literature say about combined procedure, like if you're doing cataract surgery and phaco-emulsification together? Now, this is one of the earliest data earlier when the phaco-emulsification was has come into the practice, but it was not that popular. 1996, actually, this was published by Joseph Caprioli. 40 eyes plus 40 eyes, you know, it was a case control study, but retrospective. Again, there's a disadvantage. The cumulative success rate at 2 years, they found, was of 62% in the group where the combined surgery was done. And this cumulative success rate is for in terms of controlling intraocular pressure, and they were all open angle glaucoma patients. And it was in 86% in trabeculectomy group. So clearly, the trabeculectomy group seems to be doing, you know, much better than the combined surgery group in this particular study. And also, you can see the graph on the right side. The combined surgery is the solid bar upper, and you can see at all you know, follow-up intervals up to 1 year, the intraocular pressure is lower in the trabeculectomy group as compared to the combined, you know, the phaco-trab group. And these are the eyes where you had 5-fluorouracil used in both the groups. The 5-fluorouracil was commonly the mitomycin C was not that commonly used at that time. Though it had come into the practice, but not that commonly. 5-fluorouracil was more popular at that time. So this study is 5-fluorouracil, and you can see there's a clear difference in favor of trabeculectomy rather than combined surgery. However, as I think with the passage of time, I think the techniques have improved. The glaucoma surgery techniques have become better. We have, you know, better microscopes, better equipment, and also the phaco-emulsification actually has evolved a lot over a period of time. And this study is the last one, is a meta-analysis that I could find, that, and is done this year only, February 2021. This was published. So this was they looked at the, you know, large body of literature after the introduction of the phaco-emulsification. The studies, older studies, they were not considered where EEC, extracapsular capsular cataract surgery was done. That was not considered. So we are, you know, in the phaco-emulsification era. They looked at almost 1,000 studies, and they found that about 25 of them were worth. They had, you know, the level of evidence was a little better in these to be considered for meta-analysis. And what they found that IOP control was more or less similar in both the groups. There were fewer complications in the combined surgery group. Now, this was a little change from what we saw earlier in literature. Earlier, we saw that the combined surgery has more complications, and that is also, I think, the impression most of us have. Even my personal experience is that I tend to get a little more complication whenever I do phaco-emulsification plus trabeculectomy when I combine these two procedures. Trabeculectomy alone, it gives me a little, you know, more confidence. But the downside again was that none of these studies had a higher, level of the level of evidence was still low in these studies because most of them were non-randomized, and also they were retrospective in nature. So we know, the level of evidence is highest if you have a non-randomized, kind of a controlled, non-randomized studies. The retrospective studies represent real life situation, but I think the quality of data would be a little low. So the overall level of evidence was low in these studies, but it does suggest that combined surgery can give you good results, good IOP control, and as well as comparable complications profile like trabeculectomy. So that is there. And now a little bit about phaco-emulsification for MIGS. MIGS stand for minimally invasive glaucoma surgery. So you would be hearing more and more, these days, hearing more and more of these procedures in these days. There are a number of MIGS procedures, so I'm not going to talk about all of them, but a few of them I'll definitely talk, which I think are kind of, which are either more common or, available or might be available to us at some stage. Most of them are not available in India. So place in glaucoma management is still evolving, MIGS. MIGS is mostly used along with cataract surgery. So most phaco surgeons are the main users of MIGS, devices or procedures. Glaucoma surgeons are not that enthusiastic about doing MIGS procedures. Impact of cataract surgery plus MIGS. So now, what is the impact of this surgery on patients? Number one, it does lower intraocular pressure, at least that's what's claimed. It does improve quality of life because you're removing a cataract also. Effect of cataract surgery or MIGS. Now, are these benefits because of MIGS or are these only because of the cataract surgery? That can always be debated. And here you have to remember the table that I showed you earlier, where I suggested, is there in literature that the IOP reduction following cataract surgery is a function of baseline IOP. Now, most of these MIGS are done when the IOP is kind of in the mid-20s, I would say. It's not too high, too low. So more than 20 millimeters of mercury, 24 millimeters of mercury, somewhere around that range. And that's the range where cataract surgery also have a significant IOP reduction alone. So it's kind of a questionable, as sometimes many people question whether the IOP lowering is because of MIGS or just because of cataract surgery. So that issue still remains. The quality of life improvement is because of cataract surgery, because you are removing cataract, the vision becomes better, there's clarity and people are happy. So MIGS, I don't think would have any role in that. But if they are reducing truly intraocular pressure, they are effective and they are preserving vision on a long-term basis, then definitely you can say they will help preserve quality of life. But the improvement is probably, immediate improvement is probably because of the cataract surgery itself. Then we have cost escalation. So that's a significant component because all these devices are very expensive, and any device would add $500 to $1,000, minimum, or maybe more to the patient's expenditure, which is quite a lot, even for the Western countries, and for other countries, definitely a much financial burden. So a little bit about the iStent, because iStent is kind of, it came with the great fanfare, it's still being used, and now they have another version of this, what you call iStent insert, which is much easier to insert. So if you do cataract surgery alone, so this was again a comparative data. So if you do cataract surgery alone, you would see a IOP reduction up to 7.4 millimeter mercury to an increase of about 0.3 millimeters of mercury. So this is the control group where you just did the cataract surgery and you had some IOP. Most of the times IOP reduction, some people have less and some people have little increase. But if you look at the iStent, iStent actually, if you combine the iStent, then you can see the IOP reduction was a little higher, 8.3 millimeters of mercury, and it didn't go on the positive side, of it. So some IOP reduction basically over the control group. And the important thing again here is that number of medications required to control IOP in the iStent group was, better. That means they needed, there was more reduction in number of drops needed to control IOP. However, if you, another thing which is advocated is that you can put multiple of these stents. So one stent, you can see reduce IOP by about 15 to 20% somewhere. The two stents would up to 30% as per this data. And 3 stents would be like 8.3 millimeters or 41% from the baseline. So what it appears like is that if there's a one stent, it's kind of questionable whether it's really working or not. But if there are 2 stents, maybe there's some benefit, and 3 stents, it looks like that, okay, there's an IOP reduction. Now, one thing we can deduce from this data is that you need multiple stents, number one, to achieve any significant amount of IOP control, at least 2 iStents, if not 3. The other thing is that because there's an incremental decrease in IOP with 1, 2, and 3 stents, so probably there is some effect. So you can't say that they don't work at all. The IOP reduction may not be clinically significant when you're using only one stent, but when you are using multiple stent, clinically significant IOP perhaps, reduction in IOP perhaps can happen. So that's one thing. And other thing is that, of course, to achieve that, you need multiple stents. And that also means that if one stent is $500, so you have $1,500 for 3 stents. So that actually pushes it beyond, usable range. So the cost benefit ratio is actually very poor from patient's point of view. Zen implant is another, I'll mention it here again, because Zen, to my mind, this is the implant which actually gives a good IOP control, at least in the beginning. It works much like trabeculectomy because it's connecting the anterior chamber with a small tube into the subconjunctival space. And because you have not done any dissection in the subconjunctival space, the fibrosis will be less, and you'll have a better IOP control. But in practical terms, the fibrosis still happens, and many of these patients would need needling or application of mitomycin C in that area. But still, it does give you an IOP control, which perhaps better than other MIGS devices. This can be done independent of the cataract surgery. You don't need the cataract surgery for this procedure, but can be combined with the cataract surgery as well. I'll talk a little bit about trabectome because this is something which this is basically you're removing a strip of the trabecular meshwork. So you're just removing the trabecular meshwork. As we know, the area, the site of a resistance to the aqueous flow from the anterior chamber to the Schlemm's canal is trabecular meshwork. So if you remove the trabecular meshwork completely or part of it, the aqueous should get access to the Schlemm's canal easily and should be drained through the collector channels. Now that can happen if you're removing the trabecular meshwork. So there, the trabectome, and there are 2 ways of doing it. One is using a Cox blade, and other there's an equipment called trabectome which can do it. So if you look at trabectome, then again there's reported is a good 9.3 plus minus 5.6 millimeters of IOP reduction. Versus control group like 5 millimeters more in the control group. So there's a significant IOP reduction with trabectome. Now, how long it lasts, that's a big question because there's an attrition with period of time. So if you're doing trabectome with the cataract, there's a trabectome combined surgery. So trabectome or removal of the trabecular mesh or using trabectome or Cox blade and cataract surgery. So that can be combined, and that's what usually done. Now, if you look at, there are 2 phenotypes of glaucoma in this patient. One is a pseudo-exfoliation glaucoma, and another one is the POAG. So if you look at the POAG, the reduction in IOP is less actually. You can see about -7. plus minus. So there's a large standard deviation here. This is with the exfoliation group. So exfoliation group is giving you some decent amount of IOP reduction, I would say. But if you look at the POAG group, then you can say IOP reduction just about 4 millimeters of mercury, and with a almost equal standard deviation there. So that doesn't seem to be very impressive. But trabectomy is it is. I'm mentioning it because it does. It is one of the MIGS which is combined with cataract surgery and is available in India, is marketed. And also there's cheaper ways to do it using a Cox blade. So this might be worthwhile trying in some of our patients. And you think the IOP, the requirement of IOP reduction is not great, is a modest, that you want some decrease in IOP because the glaucoma is not advanced, is ocular hypertension or early glaucoma, and your target IOP range is, is not that rigid. So one perhaps can try this procedure there. So this is what we have discussed from the literature, basically what is the current scenario. So what are my preferences? So how I practically deal with these cases. So what I do is that if it is a case of angle closure glaucoma, as I mentioned earlier, my preference is to do a cataract surgery. So if you have an angle closure glaucoma with cataract, I would go for cataract surgery. I consider cataract surgery as the first choice before I do filtering surgery. So if there's no cataract, then I will go for filtering surgery. But if there's cataract, I will remove the cataract first. And as I showed you one example earlier, if the anterior chamber is totally closed in a cynical closure or and you really want low intraocular pressures, there I would like to combine the two procedures. But in angle closure glaucoma, I try to avoid a combined procedure or a filtering procedure. The first choice is cataracts. Second, if cataract is not there, then you have a trabeculectomy, and only then I would consider a combined phaco-trabeculectomy. In POAG, I would consider a trabeculectomy before cataract surgery as far as possible. But if the visual rehabilitation need is high and you do need there's one-eyed patient and there's advanced cataract, sometimes they come with mature cataracts. So there we would like to do a combined surgery, to give the visual rehabilitation as well as the IOP control. And in pseudoexfoliation glaucoma, I would like to do early cataract surgery, because if you let the cataract mature, become harder, it becomes a little difficult to operate, and chances of complications go up. And with time, the zonules become weaker, the capsule will become unstable. So it's better to operate these patients early. My threshold for glaucoma surgery is also low, because we know in pseudoexfoliation glaucoma, the fluctuations are high and they are more prone to have glaucomatous damaged at the optic nerve, and also they deteriorate faster. So here, if you have both are there in equal measure, then I would consider combined surgery again. So here my threshold for combined surgery is a bit low. Of course, these decisions are modified by many other factors. Like I said earlier, the amount of glaucoma damage, the target IOP requirements, economy of the patient follow-up, and sometimes it's just your gut feeling. All surgeons have that. In a given situation, what you will do will depend on multiple factors. So that's how I deal with these cases. So to summarize, my talk, cataract and glaucoma often coexist. That's the reality, because the age group is the same. Trabeculectomy, phacoemulsification, combined surgery, all are valid options for these patients. However, you have to choose what is best for your patient. Trabeculectomy still remains the gold standard. So if whenever possible, if there's no cataract, this will be the gold standard. But presence of cataract, complicates it a little bit. And also in angle closure glaucoma, cataract surgery gives you a little more advantages over trabeculectomy in many ways, not only in terms of controlling intraocular pressure, but also the overall patient management. There are advantage of doing cataract surgery in angle closure glaucoma patients. So that's what I would prefer there. And MIGS, I said, they are less effective. They are very expensive. And their role in glaucoma management is still evolving, still not that established. So thank you very much for this opportunity again, Center for Sight. And if you have any questions, I'd be happy to take them. Thank you.
Thank you so much, Dr. Pandav. I would invite Dr. Harsh and Dr. Pradeep for their comments before we go on to current questions, if you don't mind answering.
Thank you, Vanita, and thank you very much, Pandav. I think that was so beautifully done, especially for the postgraduates. I think you have threadbare told every point about each surgery. And as you in the end very rightly said, each one is an option and one has to individualize what one does in a patient. But personally also I agree that what initially I used to think was that if a patient is having a lot of field defects and all, I must go for a combined. But that thought has changed in me also, and I have shifted quite a bit towards doing cataract surgery, especially the patients and the elite patients which I do. They don't want a prolonged post-op period. So they say that, all right, you go ahead, do a cataract, and if the pressures rise, I'll be ready for a trab later. And most of them do very, very well. So I think we are shifting a little bit towards that, and especially because so many of our patients are angle closure. And yes, the combined surgery definitely has lesser success than if you do a trabeculectomy alone. So one would rather do a cataract and later go ahead and do a trabeculectomy. All said and done, another very important thing is all the studies and what I, Vanita, Pradeep, and Pandav say is not valid for a young person, because how many trabs do they do? We have done thousands. They do a very infrequent trab. For them, doing a cataract may be so much more simpler, which again in a glaucoma patient is not that simple. So perhaps they would justify what they would do best in their own hands. And I think Dr. Pandav has very clearly defined most of the things. Prateep, please go ahead.
Yeah, Harsh, I totally agree. Dr. Pandav has done a wonderful job. It's a totally evidence-based talk, and I enjoyed thoroughly. Yes, a few points to make. We divide our patients into three categories. The patients who have a coexisting glaucoma and cataract, that is a patient with angle closure disease, the patient with primary open angle glaucoma, and the patient with secondary glaucomas. And then again, if you want to divide, then it's a mild, moderate, and advanced glaucoma. So if the patient has an angle closure disease with mild to moderate glaucoma, then obviously just a cataract surgery is an option, and most of the patients, they do very well. And similarly, if the patient has a primary open angle glaucoma, most of the patient would do very well just by doing the cataract surgery. But yes, we have to explain to all our patients that they may require anti-glaucoma medication or anti-glaucoma surgery at the later date. The secondary glaucoma altogether is a different group, and they have to be dealt differently. So related to just the trabeculectomy and the trabeculectomy combined with the cataract surgery, I would say that yes, we do the trabeculectomy alone only and when the patient has a glaucoma and does not have a cataract. The simple reason is that if the patient has a cataract as well and you do a trabeculectomy and then followed by a cataract surgery, then the risk for the failure of the trabeculectomy is more. So the bleb does not survive as long as you do just the trabeculectomy alone. So, there is a different group of patients. There is a different kind of a disease manifestation. And obviously, the different understanding. If the patient is likely to be non-compliant, then obviously you would prefer to do a combined surgery. If the patient is very well understand the condition and willing to put the drops, then I would always prefer to do a cataract surgery alone. So, it has to be individualized, as Harsh said correctly, and Dr. Pandav has also explained correctly. Yes, go ahead with the question and answer, Dr. Vanita, and if you have any thought.
Yeah, I mean, there are lots of I don't think postgrad students have posed so as much as I see a few from perhaps ophthalmologists, because the questions seem like that. But what I want to first understand is that you say trab first in POAG. Now, these patients, if they don't have cataract, about 30% will develop cataract in the follow-up period. So if they have some cataract already, why not take it out?
Well, I think that's a good question. And that's why the debate is actually regarding the, mostly is related to open angle glaucoma. We have a trabeculectomy. And so if the cataract is not visually disabling the person, he is able to go about his, life. So there's no urgency in doing a cataract surgery. That's number one. And we know that trabeculectomy is the gold standard, and that will give protection, because here, now if you look at the cataract versus glaucoma, if we say that both are in the equal measure there, then the precedence goes to glaucoma, reducing intraocular pressure, because the damage that's happening because of high pressure or glaucoma-related damage, that is actually irreversible damage. So that's important. So that's why protection to the optic nerve is the priority. Now, even if these patients, they develop cataract later on, they will have some visual, decrease in visual acuity, but that's a temporary phenomenon, and one can always go in and remove the cataract. So urgency is in reducing pressure or controlling pressure. Urgency is not in removing the cataract. So okay. That's the one reason.
But as you said, and I'm sure we've all experienced, and I particularly have noticed this, that if you do a cataract surgery after trab, the chance of the trab failing is pretty high.
That's true. So, and that is actually.
So it's like a catch-22 situation.
Yes,
you are avoiding combined surgery because you're saying that the outcome is likely poorer, versus you are doing a trab first and then cataract surgery later and risking failure of the bleb.
That's true. So that's why. So if the cataract is at a stage where you expect that the person would need cataract surgery in another 6 months, then better to do a combined surgery. But if the cataract is not at that stage, then I would like to separate them out.
Would that change in angle closure glaucoma? I mean, we're talking about uncontrolled. We're not talking about controlled.
Yes.
Would you do even if it's early cataract, it's better that the lens comes out along with trabeculectomy, or not?
I think lens comes out without trabeculectomy. So that would be my first choice.
Okay. Then in that case, are we talking, these are questions I'm really surprised. Are we saying that we are only worried about quality of life in terms of vision and not quality of life in terms of the medication the patient is having to do and may be intolerant to, the amount of money he or she is spending on it, and the number of times that they have to remember? I know patients who keep have alarms, and I get irritated with alarms because they're so jarring. So what would you have to say about the quality of life related to anti-glaucoma medication if you're only doing cataract surgery?
I think that's again another very important issue and very practical issue, basically, because most patients would face that, and we know the compliance rates as they are. But if you're doing cataract surgery only for angle closure glaucoma patient, the chances are that he will need very less medications. As I shown in my case, that patient was drug-free for 2 years after phaco-emulsification alone. So the number of drugs, and as I showed in the data we have published, the number of drugs, anti-glaucoma drugs, there is a significant reduction in angle closure glaucoma if we do phaco-emulsification alone. So that actually is a improvement.
There is reduction, no doubt, but there none without medication.
They would be medications as well. They wouldn't really.
Especially in, someone else has pointed out that in your mild to moderate, in that paper, in your mild to moderate group, there was, a 40%, 50% drug reduction, but none were without medication in the mild to moderate group. So, we're not talking in terms of the advanced glaucoma group, which you yourself said that some of them went on to require.
Yeah, 20%. So if you look at the other way around, if we were not following this strategy, then all of those advanced glaucoma would need surgery. And here you could avoid surgery in 80% of them. So surgery is associated, fears that are real actually, right? Now, coming to the drugs again, even if you do trabeculectomy, this is actually not a guarantee that you will be drug-free. So in fact, most of the trabeculectomy patients, they would need, some 1 or 2 anti-glaucoma medicines as you go, beyond 1 year, 6 months, 1 year. So even trabeculectomy doesn't guarantee actually a drug-free period.
No, but definitely the chances are much more, and literature would suggest, and I have looked at my data also, about 80% would actually go on till 2 years without drugs. No, you won't agree?
I think much less. I would say much less than. Yeah.
Okay.
And when 80% success rate, this kind of a qualified success rate, overall success rate for trabeculectomy. It's not the true success rate in that sense. And the other thing is that if someone is actually have problem with the drugs or allergic or can't use, you can always go in and do a trabeculectomy at a later date. So that option is not closed.
No. Intolerance to drugs then gives you red eyes, and the more you use drugs, the lesser chance of success of your trabeculectomy. So I find that it's always a catch-22 situation. You're always trying to be at the, you want to be at the top, but you're at the tail. So
see, glaucoma surgery is like that. I mean, there's no perfect solution. But see, if after you have done phaco-emulsification, the number of drugs is less. So the drug-induced failure of subsequent surgery chances are also theoretically reducing. And all these patients, they would be on multiple drugs before you do phaco-emulsification. So I think that argument is not actually holding here. That if you're giving drugs to these patients, the subsequent glaucoma surgery will be more deemed to failure. I would say on the balance, it will be less number of drugs required and less, effect on the subsequent surgery.
Okay. And when you say amount of glaucoma damage, do you have a particular way of assessing that? Is it on structure? Is it on function? Is it on visual fields that you're talking about? Or how do you decide that your surgery, combined surgery, or that is a modifier of the surgery, the scheme that you presented to us?
Yes, I think just the way we usually do, both structure as well as function. So if you are looking at the optic disc and you have a, there's no rim there or very little rim, so what the center advanced stage, but also the visual fields, the usual classification, like if you have a mean deviation of 12 decibels also. So beyond that, you will classify it advanced. So we follow the same thing basically.
In the real world, most of our patients, they do present with closer to -20 mean deviation than minus 10. Is that not your experience?
Yes, many of them would have that kind of visual field effects.
And so if there is a visual field defect that is approaching fixation or has involved fixation, then what would your strategy be?
Again, that's a bit of a difficult situation, but we definitely need low IOP in these. And I would be inclined towards the filtering surgery in those patients. Though I'm being mindful that you could lose vision, but then that you have to discuss with the patients and a kind of understanding between the two, because these are the eyes which will definitely need lower IOP. So they would be the cases where filtering surgery should be a part of whatever strategy chart out for these patients.
Right. And the first patient you presented, the one which you mentioned again, the patient whose pressure dropped from 34 to 14, I believe, with no drugs for up to 2 years. Could it be a lens vault which was causing angle closure in that case?
Yeah, it could be.
And
I think that's one of the things I didn't mention in my talk.
Yeah.
I look at the biometric profile for all these patients, and if they have a shorter axial length and a lens thickness and the vault, so these three things actually we look at. There's no kind of set formula that, okay, if this thing is beyond this, then I will do this, but definitely that is in the back of the mind. And if you have a thick lens or shorter lens, so the decision to take out the lens.
Well, that patient did have a fairly thick lens, 4.9, as you mentioned.
That had a thick lens, yes.
Yeah.
Yes.
But then the question arises: do you do an ASOCT for all such patients or angle closure patients?
Not for all, but we are doing more and more.
Okay. And there's one more comment here which says that Professor Tin Ong was here. He delivered us a lecture a few months ago. And in that, he mentioned a study from Singapore where he said that they now have concluded that goniosynucleasis really is not giving any added benefit when you are adding it to phaco. What would you have to say to that? Because you said
I agree with that. I also don't do it. I started doing it in between.
Yeah.
And then I realized that I was actually getting a little more inflammation in the postoperative period, and also had a little hyphema in a few patients. So I thought maybe I'm actually doing not the good thing, but I'm doing bad to the patient. And the outcome is whether the benefit is kind of questionable. So for a questionable benefit, you want to do something could be harmful.
Right. Okay. So that's exactly what I told him, that I seem to get a lot of inflammation. I don't recall hyphema, but definitely inflammation, and so I stopped. And several patients went on to develop more synechiae in the angle. So as a result of that inflammation. Right. And there's also a comment that there's a recent study. Your MIGS studies are all a few years old. And there has been a recent study of iStent alone. Most MIGS are compared with phaco alone as well. But this one was done iStent alone, and they have a long-term follow-up, and it has shown that IOP decreases close to 30%, 28%.
How many iStents? They put 2 or 3? Because one doesn't work. Usually they do 2. Sometimes they
average.
So that's why I said, like, there is a bit of a dose response. That is what I was trying to say. That if you put 1 iStent, 2 iStent, 3 iStent, so there's a dose response curve is there. So that means iStent does reduce IOP. Now, in a given patient, it's significant, clinically significant or not. So that actually is the point of contention. So it's not to say that it doesn't reduce IOP.
No, so these were patients who were actually either pseudophakic or were phakic, and cataract surgery was not performed. So what they're doing, what they're saying is that they have cut out the benefit that, the presumed benefit related to cataract surgery. That's what was. I think that was quite a bit. And is there anything else I picked up? Unless I think they have logged out, Dr. Harsh and Dr. Pradeep. So no, someone's there.
We are there, but
you're off.
I think you're already grilled him enough.
These are comments that have come through.
Yes. No, very good. I think that was very beautiful discussion. It was really fruitful. Really fruitful, because everything was threadbarely discussed. I think that was very nice.
It was coming to me through my phone. I've been checking all
yeah. No, that's great. So,
so you were
right. It has to be senior people.
Yeah, so it postgrad trainees, would definitely benefit by hearing all this this debate.
Yeah,
I think it's a debate, and I think it goes on.
yes, it goes on.
Yes. Well, thank you very much, Dr. Pandav. We really appreciate your time and your effort. We hope we will be meeting in GSI in December.
Yes,
in December, we look forward to it.
Definitely.
And hopefully, fingers crossed, it will happen. But thank you very much. Have a very good evening.
Thank you indeed for the invitation. I enjoyed interacting with you and some great questions there. Thank you so much. And it's always a pleasure to see Harsh and Pradeep. And
okay, bye.
Thank you very much.
Good night.
Thank you, sir.
Good night.
Good night.